I thought maybe we could just start by talking a little bit about, what happens when you call in or to make an appointment, and when that might be that you might want to make that first call. Lots of different reasons to come and see a fertility specialist, whether it be that you and your partner are starting to think about family planning and talking about that. If you happen to be in a heterosexual couple and you've been trying for a year or more, if you're under 35, or 6 months or more if you're over 35, those are good time points to come to see a fertility specialist. If you are a same-sex couple and starting to think about options for family building, of which there are many, that is a great opportunity as well. So these are all times when you might want to come in to start that treatment. We're starting to get a couple of questions, so I'm just going to pop in and answer some of those. One question that came up is, how soon can I have my frozen embryo transferred after switching to a freeze-all protocol mid-treatment? This is a great question, and it happens not infrequently. We have a lot of different reasons for converting to a freeze-all cycle. And so I think the answer is typically at the earliest time point, it would be the cycle following IVF. If you're planning to do what's called a programmed thaw, using estrogen to thicken the lining and progesterone to support the lining, that's something that often can be started the following cycle. Or sometimes it's this, you have to take a month off depending on timing. If you're doing a natural cycle, sometimes we need some time for the ovaries to recover and to kind of get back to a normal menstrual rhythm. So, I think we're really looking at, after a freeze-all, when you have your retrieval done, getting a period would be the first thing. And then after that period, it's either starting estrogen potentially for that thaw cycle, or waiting the month, and the following normal period, you'd start a transfer cycle. So 1 to 2 months. Another question coming in is, after having my first child, how long before starting treatments to my second child? This is a great question, and one I talk with a lot of my patients about once they're successful. I think usually the answer is it depends, but for my patients, when we sort of discuss timing on this, my recommendation is typically to give a call back to the office to schedule an appointment at the earliest around 6 months postpartum. If you're an older patient that really doesn't have, embryos frozen and you're coming back for IVF, being cognizant of timing, like in your 40s, you might even want to consider calling like 3 months postpartum to sort of come in and start the process of talking about updating testing. Most often, the recommendation is not to undergo embryo transfer until at least 1 year after your last delivery. And this is really because it takes the body time to recover from a pregnancy. It takes 9+ months to grow a baby. It takes that long really to recover the body after delivery, especially if you've had some component of breastfeeding, that kind of thing. So I think generally I recommend call and schedule an appointment maybe around 6 months postpartum, maybe 6 to 9 months. We could typically start treatment around 1 year. And again, that time frame can be adjusted. Like if there's a little bit more urgency maybe to getting back in, usually we'll try to start the process a little bit sooner. Another question that came in is, why isn't fertility talked about as much? Many people seem to have an issue with it. Well, this is exactly true. It is a frequent and commonly encountered problem, medical diagnosis that occurs. And it has for a long time been, I think, under discussed. I think the reason for that is multifactorial, but probably a significant component of the hesitancy to talk is just that it's a vulnerable point in people's lives, couples' lives. I think on the side of females and infertility in particular, I think just in general, our discussion and the way we talk about women and cycles and understanding of reproductive system has always been something that's cloaked in mystery. This is a product of our society, and I could go on and on about this, but like it goes back, this goes back. This goes back 100 years or more, right? But I think if we're talking about today, we are starting to see that more people talk openly about this. I think the more that we see high-profile people and celebrities discussing this, the more helpful it is because it does help to start the conversation and move it forward. We're talking about 1 in 8 couples will have trouble conceiving a pregnancy. And then in addition to that, a broader awareness of our, LGBTQ patients that also have their own select set of challenges regarding fertility and talking about that more openly. So, I think our hope and goal, especially in having National Infertility Awareness Week, is let's talk about it. Let's bring it to the forefront. Let's shed light on this, because the more we do that, the more support we get, the more, hopefully federal money comes towards this. We are lucky here to have Resolve New England, which really helps to try to move the needle and push forward with initiatives that are helping patients with access to fertility care and treatment. And again, all of this is really something that we can do by talking more about it. So I think that's really a great question and comment. We have another question about IVF and endometriosis. So endometriosis is an issue that can occur where the cells that line the uterus, which are called the endometrium, make their way out of the uterus into the pelvis and can deposit on other areas, the bowel, the ovaries, the fallopian tubes, the bladder, and cause pain, number one, scar tissue sometimes, and a variety of other challenges. Endometriosis has different stages. Some are more mild, some are more severe. So there are different ways that this can affect fertility, but certainly it affects fertility, in the sense of sometimes egg quality, sometimes because it blocks fallopian tubes, sometimes, with the scar tissue. So there's lots of different reasons why it can impact things. With IVF, I think one of the ways that endometriosis can impact the process is sometimes by women with endometriosis having less responsiveness to IVF stimulation, just due to perhaps some damage that may have occurred over time in terms of the endometriosis on the ovary. Endometriomas are cysts that can occur in the ovary. Again, these are pockets of old blood that cause cysts that can take up space in the ovary. So sometimes this, again, can lead to decreased responsiveness. Sometimes it affects egg quality. And other times people do just beautifully with IVF, even in the setting of endometriosis. So there's a wide range, a wide spectrum when it comes to that. But IVF as a primary treatment for endometriosis-related infertility is common, and we deal with this a lot here at Boston IVF. So certainly would encourage consideration of IVF treatment, if you have endometriosis and haven't conceived spontaneously with ease on your own. Okay. We have another question here that says from Jamie, who says, I had twins from a single embryo transfer. what is the probability that this will happen again, starting again soon? Great question. So not knowing the specifics, Jamie, for you of your case, I don't know if this was an embryo that was biopsied that you had transferred. So if this was a genetically tested embryo or not. But if it was a genetically tested embryo, one that's been biopsied and then frozen and then subsequently transferred, the risk for that embryo to split into two, there is reported anywhere from 1% to 3% chance. Okay, so it's still very low. It's unlikely, but we do see that it happens, and we see that it happens more often in embryos that have undergone some kind of manipulation. Again, like a pre-implantation genetic testing biopsy, or with something like what we call assisted hatching. These are things that change the outer sort of shell of the embryo and can make it slightly more likely to split. But again, the vast majority of time, a single embryo transfer will remain as a single embryo transfer growing into a singleton baby. I'd say there's one other scenario in which sometimes we have to be careful of twinning from a single embryo transfer. That's not necessarily when an embryo splits into two, but if you're undergoing a type of cycle like a natural thaw cycle, where we're actually causing you to ovulate during that cycle to prepare the lining of the uterus, in those settings, it's important to abstain from intercourse at the time of that ovulatory event, because it is actually possible to both have a pregnancy from the embryo that we transferred and a pregnancy from the egg that was ovulated that then spontaneously needs sperm in that setting. So those are the two kind of ways that often that we might see that we get twins in a setting of a single embryo transfer. The likelihood is low. So it should be very low that it happens again. Okay, we have a question. I have tried IVF twice, but had to cancel because the follicles didn't grow. I responded well to Clomid as part of the IUI process previously. My doctor was suggesting we try Clomid as part of IVF. Do you have other ideas for women who struggle with follicle growth? Hi, Christina. Thank you so much for that question. So it's really hard when you go into IVF with big hopes and expectations that it's going to solve the problem. And sometimes it doesn't, right? Sometimes we do find in various women that responsiveness to our typical IVF medications, which is injectable hormones called follicle stimulating hormone, primarily, that in some women this doesn't work. And oftentimes that's women who have either a starting follicle stimulating hormone level that's on the higher side. Sometimes that's in a setting of what we call diminished ovarian reserve. So this, maybe these terms make sense to you, I don't know, but the idea for Clomid plus these gonadotropin hormones, which are follicle stimulating hormone and luteinizing hormone, is something that I often also use in my patients with diminished response. And your doctor might have mentioned there was actually a nice study, I'm forgetting the author, but it was done a couple of years ago that was evaluating women with what we call a poor response or a diminished response to IVF, and looked at really high dose standard medications, FSH and luteinizing hormone, versus low dose medication plus Clomid. And what it found was that the outcome was at least as good with the low dose stimulation, sometimes better. And so for me, in my patient population, I've used this quite a bit, and I've had some really good success with it. So I think that's a reasonable suggestion. You can use letrozole as opposed to Clomid. That's, the same idea. So those are sort of two options to consider. There are a couple of other protocols that you could talk with your doctor about. Sometimes they're called like a estrogen lead-in, which we call a luteal estrogen protocol. But again, for your specific case, I think the recommendation of Clomid, that's my go-to for a lot of my patients, and I've had some nice success. So I really wish you the best of luck with that. hopefully it turns around this time for you. Another question, are cysts and growths seen through the ultrasound, or is there another process to identify them? So primarily to view the ovaries, our primary view is with an ultrasound. There's not really any other way to identify them that we use standardly in the office other than that. I mean, certainly you can identify with other imaging modalities, such as, MRI or something like that, cystic structures. But the primary goal with our ultrasounds during monitoring or early monitoring in the cycle is to look and see, does the ovary look normal? Is it responding normally with follicle growth? Are there cysts that are present when they shouldn't be? Maybe like at the start of a period, we expect, the ovary to kind of look nice and quiet, and sometimes cysts are present. So these are times where we use the ultrasound and potentially do follow-up imaging for them. So that's a pretty standard way to identify cysts and growths on the ovary. So I think there's another question here from a participant asking about, why might IVF not work the first time? And maybe a follow-up question to that, which is it possible to do genetic testing of an embryo after they've been frozen? So two great questions. The first thing I'd say is that the first cycle of IVF is always tricky because we as physicians look at all the parameters that a couple or a person presents with, their the female's ovarian reserve testing, the semen analysis of a partner, or maybe it's donor sperm, the hormone levels that are associated. And so I think that we try to make our best prediction of what the outcome is likely to be with IVF. But there are so many things that are uncovered in the process of the first IVF cycle that we can't always predict. For example, one of the classic places that sometimes my prediction might not work is when ovarian reserve parameters look really great for the female partner, and the semen analysis looks totally normal, or maybe we're using donor sperm or something like that. We go to combine egg and sperm after, let's say, a great response to IVF, and there's no fertilization. This is something that we can't predict. This is something that we just don't know until we see it. And in that scenario, there would have been no indication for a special type of insemination because the semen analysis looked normal. So this is just one example of like why you might have an IVF cycle that doesn't work. Another scenario might be that the type of protocol in terms of medications weren't quite perfect for you or your partner. And we just didn't get the responsiveness that we were looking for. Maybe we hoped it was better and it was kind of low. So, next time around, your doctor would take all of that into consideration, all the data that they just retrieved from that course of the cycle, and make some tweaks, change dosing, maybe change the approach. Maybe we change the trigger type, which makes a really big difference. Maybe we change the goal growth size of the follicles. Sometimes I'll say, oh, you know what? We triggered you like I normally would when your follicles were, I don't know, my goal size of 20 to 22 millimeters, but we had a whole bunch of immature eggs. So we're going to push it further, or we're going to change our trigger type, or we're going to change our insemination type. Sometimes, even when all of that goes well, good egg yield, nice looking sperm, normal fertilization, we then see that there's problems with blastulation. So this is growth and development of those embryos from day 1 of fertilization to day 5, when we want them to be these like lovely, beautiful blastocysts. Sometimes that doesn't happen. And this one is really hard to explain. Is it something with the eggs? Was it something with the sperm? Was it something with the type of, medication dosing that, caused this? So in short, there's a million reasons why the first IVF cycle might not look perfect, despite excellent care from your said doctor, trying to make this the best they could make. And the goal really is to just take what we can learn, tweak it to make it better the next time. Most of the time we're successful in doing it. So that's the good news, I think, there. I have a great question from Allison, who asks, what does a typical first step look like for a lesbian couple to begin this process? So this is a great question. I think the first step is calling to make an appointment. And really, this can be at the very beginning stages of considering family planning, and like before you've even really had lots of time to sort of dive into how do you want this to look. Maybe you don't even know what the options are. So the best first step is to just make an appointment, come on in. And what we'll talk about is, what are your family planning goals? So for some couples, this might look like using donor sperm and having what are called therapeutic donor inseminations for one or both members of the couple to achieve pregnancy basically spontaneously for each of them, and then for each of them to individually carry. For other couples, this might be an idea where, one partner is thinking that they'd like to donate their eggs to create embryos that the other partner will carry, or vice versa. Or maybe it happens for both partners in the couple and they swap. This is called reciprocal IVF. So there are a lot of different directions that you can go in, I think, as a same-sex lesbian couple. And all of those are things that we'll talk about at an initial visit. We'll also talk through typically both partners' histories. We'll talk about potential testing for both partners if both partners do in fact want to be involved, or for just one partner if it's just one partner that wants to undergo donor insemination. So we can talk through all of those tests and kind of lay out the options and then go from there. But I would say don't hesitate to make a first appointment, even if it's just information gathering for maybe next year, or maybe we'll do this in 2 years. It's always good to get the information up front so that you can kind of know what the process is going to look like for you when you really want to go forward with having a baby. Next question. What foods are good during a frozen embryo transfer, and what teas are safe? Everybody loves to ask me about food. And what I would say is I have learned from my patients that there are foods on the internet that they recommend. But from a medical standpoint, really, we're talking about just eat healthfully. Okay. There's no magical food that's going to make this work or not work. Okay. I mean, with the exception of staying away from alcohol and, any other kind of toxic substances, smoking, drug use, staying away from alcohol at time of transfer and while waiting for the pregnancy test. Like outside of that, really everything else is on the table for healthful eating. And there's no one food in particular that I would push you towards. In terms of teas, again, this is also a very popular question. I think a lot of people are looking to do all they can, add something to the process. But I'll tell you from a physician standpoint that it's much easier not to be adding in loads of herbal substances because we don't know how they react and respond. So what I would say is, if you're just like drinking a cup of tea for your morning cup of tea or your, an evening before bed, fine. I would say, keeping any kind of caffeinated beverages ideally to, 1, maximum 2 a day. If you're drinking herbal teas, going with non-medicinal herbal teas. So things like, like chamomile or berry teas that are not meant for medicinal purposes, that's going to be better because we can't regulate what are in these teas and these foods. So, my recommendation is sort of not to go down that rabbit hole of like fertility teas, because these things, they are more of a hindrance than they are going to be helpful. All right, let's see. Other questions. How quickly is your office able to see new patients? Typical booking is 6 to 8 weeks out. And I know that seems like 100 years, but the wait is worth it. I think I would just say, you're going to get a 1-hour appointment with any new doctor that you see in the practice. We're ideally going to have any records you have before that. We're going to be able to dive deeply into your history and go through a lot with you at that visit. And then from there on out, it's a little bit more streamlined. Okay. It's easier to come back in. It's easier to keep moving on. But the initial booking is about 6 to 8 weeks. Okay. Benefits of genetic testing is another question. Kind of a loaded question, but I'll see if I can dive in quickly. We are looking at, when we're talking about genetic testing, I think likely there's two ways to think about genetic testing. There's genetic carrier screening, which is a standard offering to new patients coming in who are trying to conceive. Carrier screening looks at what recessive diseases do you carry within your genetic code, what mutations might you carry that can potentially be passed on to a child if your partner also, and kind of confirming or seeing if your partner also is a carrier for those things. This helps us to avoid difficult and sometimes deadly childhood diseases, things like Tay-Sachs disease, cystic fibrosis, that's more chronic disease these days, but spinal muscular atrophy, a huge array that we test for. And I definitely recommend this for any couple coming in because, if you're here, we want to make sure that you're going to have a healthy baby. So doing that genetic testing up front makes a lot of sense. I think the other type of genetic testing that you might be referring to in the question is something called pre-implantation genetic testing, which is in the most commonly used fashion is really chromosomal testing on an embryo. This type of testing is a little bit more controversial. It is most commonly seen in older patients. So in women who are over 35 or certainly like over 37, 38, this would be something to consider because as women age, egg quality changes and declines and makes it more likely that when egg and sperm meet and an embryo is created, that embryo may have chromosomal problems with it. Now, most of the time, chromosomally abnormal embryos will not implant. Okay, they just will end in a negative pregnancy test. But sometimes they will implant, and if they do, most commonly that would be end in a biochemical pregnancy or a early miscarriage. But sometimes they do seem to be normal, and you only find out that they're abnormal, say, for example, at a 12-week ultrasound or something like that. So the genetic testing helps us to eliminate those abnormal embryos from the pool that we would transfer, and in theory, decrease the risk of pregnancy loss, especially in older women. But what we've seen in younger women is that that's not an absolute guarantee. And in fact, for women under 35, the most recent data that we have suggests that pre-implantation genetic testing does not, improve speed to a healthy pregnancy or likelihood of conceiving, at least with the first IVF cycle. Now, there are caveats, just like there are to everything else with that. If you've suffered a number of miscarriages in the past, this might be something that you really want to think about to kind of direct you more towards the healthy embryo up front, okay? So there's a lot of ins and outs of the pre-implantation genetic testing, but that's just kind of a little bit of a highlight to mention. We have another question that says from Katie, who says, I just went through my first round of IVF. Clomid or a drug like that wasn't used. Why might that have been? So Katie, you may have heard me talking a little bit about a situation in which a patient did use Clomid or was being recommended Clomid for her cycle because she had poor follicular response. Typically, Clomid is not first line medication that you would typically use in an IVF cycle if ovarian reserve is good. And so when ovarian reserve is on the higher side, it's not so standard to use Clomid. Clomid is usually used when we think there's not going to be a great responsiveness to our standard IVF medication, which is follicle stimulating hormone. So the fact that you didn't use that is not surprising to me. That's for first IVF, probably the most common two medications are follicle stimulating hormone and luteinizing hormone alone. And those usually come in the brands Gonal-F or Follistim, plus or minus Menopur and low dose HCG. So that's pretty standard. Another question from Carolina is, how long after a successful IUI and birth can you try again for another? So, I think this again, kind of, Carolina, goes back to what we were talking about with time to next pregnancy. I think once you get regular periods after delivery, typically if you're breastfeeding, that might not occur until it's like 6 to 9 months postpartum. At that time frame, you could start thinking about proceeding towards IUI. Usually for my patients, we talk about starting treatment around the 1 year postpartum mark, typically, unless they're, maybe over 40. And again, this just kind of goes back to health of the uterus after delivery and ideal time for what's called an interpregnancy interval, which is typically a year to a year and a half. Great. So I don't think we have any other questions coming in right now. And so I think I would love to just sort of wrap it up by saying thank you first for joining me for this question and answer session. It's really nice to hear from people about what their thoughts are and what their concerns are. This is the same exact type of conversation I have with my patients here in the office. There's so much we know about fertility and infertility. There's also still so much we're learning. And so, I think it's always important that we are really open and honest about what are the things that we know and can share with you, and where are our gaps in knowledge. And we're working on all of those as we go. So anyways, thank you so much for joining me, and I hope you have a great rest of your week. Take care.